As we round out yet another year of this pandemic, clinical microbiologists have not slowed down. We have not slowed down in our response to the pandemic or other day-to-day testing needs, despite the constant reagent backorders and personnel shortages. And equally as important, we have not slowed down in publishing high-quality, informative, and clinically relevant papers, which have really spanned the gamut of clinical microbiology. From antimicrobial susceptibility testing to next-generation sequencing assays and AI to evaluating of new high-throughput assays for a variety of pathogens, the field continues to expand at an impressive pace. So today, 3 JCM editors are going to discuss some of our favorite and most impactful papers published in the journal in 2021. Welcome to Editors in Conversation. This episode is brought to you by the Journal of Clinical Microbiology, available at jcm.asm.org and on Twitter at jclinmicro, and is supported by the American Society for Microbiology, which publishes JCM. So before we dive into these papers, if you've listened to this podcast before, you'll note that I am not Alex McAdam, the editor-in-chief of JCM. My name is Ellie Thiel, and I'm an editor for JCM, and I'm the new co-host for this podcast alongside Alex, who, as many, if not all of us can agree, has done an absolutely phenomenal job with this series over the past few years. So thank you, Alex, for keeping all of us informed and up to speed on the latest JCM publications, and for inviting me to join you on the podcast.
Thanks, Ellie. I am so happy right now. I am delighted that you're joining as co-host. And just to be clear, you're co-host for the whole thing, not just this episode.
No, that's great.
So
Thanks,
we'll be
Alex.
hearing lots more from you.
Yes. So also joining us today to discuss her favorite JCM papers is Dr. Trish Simner, who has been on this podcast before, including on last year's edition of the Best of 2020 JCM papers. So welcome back, Trish. And can you please introduce yourself for the audience?
Thank you, Ellie. Hi, I'm Trish Simner. Hi, everyone. It's great to be back and to be among such great guests or companions with me here today. And so I'm Trish Simner. I'm the director of the Bacteriology and Next Generation Sequencing Lab at the Johns Hopkins Hospital, and I'm also an editor for JCM.
Awesome. Thanks, Trish. So each of us have selected 3 of our favorite JCM papers from this past year without restriction. But I will say on behalf of all 3 of us, that was a difficult task, given the wide variety and really just great manuscripts that have been published over the past year. But we selected these papers and we'll present them in no particular order. And we'll start with Dr. Simner today. So Trish, what is your first favorite paper?
Okay, so I'm going to kick us off with an article entitled The Performance of Fully Automated Antimicrobial Diffusion Susceptibility Testing Using Copan Wasp Colibri Coupled to the Radiant Inline Carousel, an Expert System. This was published in JCM in September of this year, and it was published by Dr. Cherkoui's group from Geneva, Switzerland. So what they did is they compared the categorical agreement between Vitek 2 system and Diffusion AST testing, and they on the WASP TLA they used 2 modules, the Colibri coupled to the Radian, and they also looked at the accuracies not only as the group of organisms but to the species level, and looked at throughput and workflow. So if you are not familiar with the WASP TLA line, which I'm not familiar with the entire line, the Colibri is part of the WASP TLA line, and it's the unit that is the colony picker for MALDI-ID and the McFarland suspension prep for AST testing. If you haven't seen it before, there are some nice YouTube videos online. That's what I was doing this weekend preparing for today. And then the second unit is the Radian module, and the module consists of 2 parts. The first part is the carousel that can contain up to 50 discs and dispense anywhere from 1 to 8 discs depending on the protocol. And it can perform AST or set up AST for 10 strains in 44 minutes. The second part of the Radian module is the expert system, which is a software that is connected to the WASP Lab web app. And the software automates reading of the zones of inhibition and applies CLSI or UCAS breakpoints in interpretation depending on your lab. So if you're going to go and check out this manuscript, which I recommend you do, figure 1 in the manuscript is really nice because it demonstrates what modules are used for what in the process. So overall, they tested 718 strains in the study, which included 675 non-duplicate clinical strains, including both gram-negative and gram-positives. And they also included a challenge set of my faves, 43 carbapenemase-producing Enterobacterales. The overall categorical agreement for all organisms was 99.1%, which ranged from 98.6% for Pseudomonas aeruginosa to 99.4% for the Staphylococci and Enterococci. So they compared their automated disk diffusion to Vitek 2, but performed discordant analysis by broth microdilution plates available through Thermo Fisher. And so the most important cause of very major errors that occurred in this study occurred with the Vitek 2 system for Pseudomonas aeruginosa. And this was related to the presence of heteroresistant populations. And they could see these heteroresistant populations by disk diffusion because you could see colonies within the zone of inhibition. They also confirmed heteroresistant subpopulations in the study by gradient diffusion method. Another source of very major errors from this study was again in relation to Vitek 2 with trimethoprim sulfamethoxazole and the coag-negative staph. Among the 43 CPE that they challenged the system with, 2 OXO48-like organisms were missed by the Vitek 2, but detected by the disk diffusion method, even by applying the most stringent UCAS CPE screening protocol. Because the MIC falls lower on the dilution, the lowest dilution on the Vitek 2 for meropenem wouldn't have been able to screen positive for them to do additional testing for carbapenemases, so they missed 2 OXO48-like organisms because of that. I also really liked that they looked in this study at the stability of the discs within the carousel. So the carousel is not equipped with a cooling device. And so they did 8 independent replicates setting up discs that were in the carousel and looked at setting up their QC strains at 15 minutes and then up to 11 hours and 30 minutes. And they used these different time points in between the 15 and 11 hours. And they decided on those 11 hours and 30 minutes because of the laboratory work hours that they have at that institution. And so overall, I found that this study presents a nice study looking at a fully automated solution for antimicrobial disk diffusion susceptibility testing for total lab automation users, and really is the ultimate comeback of the cost-effective reference disk diffusion method as a primary AST method in the clinical labs. I really see this as disk diffusion switching from a secondary AST method to now one of the primary methods, especially for total lab automation users. I did follow up with Dr. Charqui over the weekend, and he responded back, and they actually have been live with this testing now for a couple months, and they say that 97% of their daily AST volumes have now converted to this fully automated disk diffusion system on their on the WASP total automated lab automation system. And I quote, "It's a real success," he says. The residual 3% were really fastidious organisms that required additional methods that are performed offline. So I really like this study and really see disk diffusion as a comeback. Just another addition is there's another great read on total lab automation by Dr. Carissa Colbreth, benefits derived from full laboratory automation in microbiology, A Tale of 4 Laboratories, was published in the March edition. It looks at FTE relocation, productivity, cost per specimen, as well as cost avoidance, comparing the utility in various laboratory sizes. So it's really nice because regardless of the lab size, they do demonstrate improved efficiencies with total lab automation in that study as well.
Trish, what's the role of disk diffusion testing in your laboratory right now?
Yeah, so we use diffusion testing as a secondary method. So if it's an agent that's not on our primary automated panel, we'll set up sometimes diffusion. It's also our reference method when we're confirming unusual results. So we'll set up diffusion. And then for some of our non-fermenters, especially those from cystic fibrosis patients that tend to be more mucoid or slower to recover, we'll set up a diffusion panel for AST methods.
Awesome. Thanks, Trish. Just a quick question, reading through this, I really liked the table 3 where they compared the Colibri coupled to Radian, and it seemed like there really weren't any major limitations to that system. Do you foresee any limitations, or is it really the next best thing?
Yeah, no, it really stood out as being, an efficient methodology. And I do really think that this will be, with total lab automation users, the comeback of diffusion as a primary method. And so, yeah, I didn't see any really big limitations that popped out. And it speaks to Dr. Charcouy saying that, that 97% of what they do. And again, the major limitations will be some of these more fastidious organisms or organisms that have different growth requirements or media that might require additional testing, but that might be something that we can sort out in the future.
I always think with automation that it's a success if you can get, 80% onto the platform. There's always going to be stuff that's going to have to be off platform. That's okay, right?
Right, exactly.
Yeah. Awesome. Thanks, Trish. Alex, what's your first favorite this year?
Yeah, my first, well, I limited myself to papers that I hadn't talked about at ID Week because I did a best of presentation there. So I ended up with some really nice virology papers and then a sort of a paper out of left field that I'll do as my third one. But the first one I chose is called Nasal Swab Performance by Collection Timing, Procedure and Method of Transport for Patients with SARS-CoV-2. And it is by Drs. Callahan and Arnaud as first and last authors, and it's out of the Beth Israel Deaconess Medical Center, which is just a stone's throw from here. Now, that's not a very intriguing title, right? We've seen lots of papers on nasal swabs as methods for collecting samples for SARS-CoV-2 testing. But these authors went a little bit further than most of those papers do, and that's why I particularly like this one. So I'll tell you a little bit about it, and you'll see where they went farther. So we're all familiar with the advantages of nasal swabs over nasopharyngeal swabs for testing for SARS-CoV-2. It's much more comfortable for the person who's being tested. People can self-collect a specimen, or it can be collected by a healthcare provider. And it also gives us some flexibility in terms of supplies. So if you're out of nasopharyngeal swabs, you can use other larger swabs for nasal samples. But there have been a lot of conflicting results in the literature with papers either showing that nasal swabs are about as sensitive as nasopharyngeal swabs or that they're less sensitive than nasopharyngeal swabs. Nobody that I know of has found that nasal swabs are more sensitive than nasopharyngeal swabs. So nasopharyngeal swabs continue to be, to my mind, the gold standard. So what did they do in this paper? This is a multi-arm study, and it has so many arms, in fact, that it makes it a little bit difficult to read the paper, but I'm going to focus on the ones that mattered. They were trying to do several comparisons, and I can see why they were doing these. But they had 308 subjects total, people who were tested, and they had two different clinical scenarios. People who were being tested at their initial presentation with symptoms of COVID-19, or people who were being tested in follow-up later in infection. And the range there was 5 to 30 days after their first positive test. So that's two clinical groups. They had then the two different methods of nasal swab collection. They had a sort of a shallow method and a slightly deeper method, both of which were performed by healthcare workers. And then they had three different transport conditions. They used viral transport media, or they used dry swabs, or they used guanidine isothiocyanate, GITSI, which was provided with one of the collection kits. So participants were swabbed twice, once with a nasal method and once by the reference nasopharyngeal method. And for that nasopharyngeal method, they used viral transport media, and all of those samples were tested using the Abbott real-time SARS-CoV-2 assay on the Abbott M2000 real-time system. So turning to the results, there were some things here that turned out not to matter. To begin with, just as you'd expect, people who were being seen in follow-up had higher CT values on their positive samples, indicating a lower viral load, And that would be expected because the viral load is high early on, and then as time passes, the viral load declines. The transport conditions didn't matter. The two nasal swab collection methods were equal to each other, and so I'm going to pool them for purposes of the discussion. But the important results were, first, that there was a poor correlation of nasal swabs with nasopharyngeal swabs. So if we look at the overall result for all of their study subjects, the kappa value, which describes the agreement between two different things, was only 0.49, which is considered weak agreement. So there was poor agreement between nasopharyngeal swabs and nasal swabs. And if you calculate the sensitivity of nasal swabs for all comers, it was only 44% compared to nasopharyngeal swabs. If you look at those who are initially presenting for diagnosis, symptomatic individuals, sensitivity of the nasal swabs was 60%, but in those people who were being tested at follow-up, fell to 35%. And again, those were the people who had lower viral load. So you can start to see where this is going, and this is where it starts to get, to my mind, really interesting. The question becomes then whether the level of virus affects the performance of the nasal swabs compared to the nasopharyngeal swabs. And now that we're talking about viral load in the sample, the analytical sensitivity of the assay becomes important. And as you know, and as most listeners will know, the analytical sensitivity is the minimum number of viral particles, or really viral RNA molecules, that need to be present for the sample, for the assay to reliably detect the virus. So first, they tried to figure this out with a literature analysis, and they included a nice table summarizing that. Frankly, it didn't go very far. The studies were too variable, and the data for analytical sensitivity of the various assays were often missing. So they approached the question in a different way. First, they used the CT values from their own data to calculate the viral load in each sample within their data. And they had previously figured out a conversion factor, so they could make an accurate assessment of viral load using the CT sample. And then next, they did a little simple modeling. They asked how the kappa value would change over a range of analytical sensitivities. So their assay had a very high analytical sensitivity, and they asked, what if the assay had a lower analytical sensitivity? What if it weren't quite as good an assay? And the result was that as they increased as they made that analytical sensitivity worse, a higher number, the kappa value rose from 0.5 at a limit of detection of 100 to 0.8 to 0.9 at a limit of detection of 1,000. So I like this paper because it offers us a resolution to the conflicting results between the studies of utility of nasal swabs. If you use an assay with high analytical sensitivity, as in this study, you may find that nasal swabs will miss a lot of patients who are positive in a nasopharyngeal sample because the viral load in the nasal sample is too low. And secondly, more importantly, this can inform our clinical practice. So nasal swab specimens might be a good choice for testing patients who are early in a symptomatic infection when they have a high viral load, but we might want to consider avoiding nasal swabs if we want high sensitivity performance late after onset of symptoms when the viral load is lower. And at that time, a nasopharyngeal swab might be a better way to go.
Thanks, Alex. Yeah, one of the other statistics that they pointed out was if they had used nasal swabs, they would miss 20% of COVID positive patients,
Yep.
right? Which was a pretty large percentage. Yeah, I thought it was an interesting study. So do you accept nasal swabs?
We do, and we've thought about the concepts in this paper, and we've also thought about the satisfaction of the people who are being tested and the comfort of the people who are being tested, and in particular in a pediatric population, that matters a lot.
Mm-hmm.
So there are some situations such as pre-op where we really want the most sensitive test we can get. So there we want a nasopharyngeal swab for preoperative or pre-procedure patients, but there are other circumstances where we think a nasal swab is adequate, but we accept that we're probably losing a little bit of sensitivity that way.
Yeah. Great.
Alex,
Trish?
do you know if they did bilateral NAIRs, or is it just this one NAIR when they were doing NAIR swab?
Yeah, it was bilateral.
Okay.
And
Okay.
for the shallow ones, they had this sort of interesting thing where they would put it in a little bit and then ask the people to press press their nose down so that both sides of the nares was touching the swab, which is a method that I guess I haven't seen in other papers. But we're all just trying to figure out the best way to do stuff.
Yeah, that is an interesting approach to an air swab. It was also interesting to hear how your approach clinically varied based off of reading a paper like this. So,
I like this paper as well. I wish they had put in yet another arm of a mid-turbinate, but maybe that's too many arms. We primarily use mid-turbinates here. We in the outpatient setting anyway. We also accept nares and throat and everything in between. Nasal swabs, not the best.
The deep swabs that they described might be mid-turbinate because they said they put the swab in until they felt a little bit of resistance. So that may have been mid-turbinate. And if you count it that way, then you can say mid-turbinate and the more interior swabs were equal to each other.
Equal, yeah.
That's helpful because initially, do we have to validate, nair swab versus mid-turbinate versus, so all of the different permutations get to be complex. And so it's nice to know that shallow versus potentially deep/mid-turbinate are about equivalent. So,
Great.
Ellie, I think you're up.
Yeah, so we'll go to my first one. So the first paper I chose was by Jeremy Ward and colleagues from the UNC School of Medicine at Chapel Hill, entitled Indeterminate Quantiferon Gold Plus Results Reveal Deficient Interferon Gamma Response in Severely Ill COVID-19 Patients. And this was published in October. And I actually came across this paper while doing some investigating into why my own lab was seeing our quantiferon TB indeterminate rate more than double recently. And to cut to the chase, as this paper really elegantly showed, COVID was or really continues to be the culprit. So interestingly enough, the impetus for their study was the same as what we were observing. So their quantiferon indeterminate rates increased from a baseline of about 8.7% to over 15% in March and April of 2020. And they found that a significant proportion of those indeterminates were due to low interferon gamma levels in the nil tube, and many of those were occurring in patients with COVID-19. So just to kind of level set on the quantiferon assay, you'll remember that as part of the QFT, there are two internal control tubes. The nil tube, which basically serves to detect endogenous kind of baseline circulating interferon gamma, and then the mitogen tube, which contains phytohemagglutinin, and that's a universal T cell stimulant. And the role of that tube is really to act as an internal positive control, ensuring that the patient has sufficient and functional T cells. So for the quantiferon to result as indeterminate, you can assume that one of two things happened. Either there was an exorbitant amount of circulating interferon gamma in the nil tube, making calculation of how much interferon gamma is specifically stimulated by TB antigens in the other tubes basically impossible to calculate, or there was an insufficient amount of interferon gamma detected or stimulated in the mitogen tube, which would suggest that the patient is either severely lymphopenic or the T cells that are present have some sort of abnormal functionality. So with that in mind, to investigate a possible relationship between indeterminate quantiferon results in COVID-19 patients, this group retrospectively identified 48 patients with COVID-19 who were tested by the quantiferon assay within 10 days of their positive COVID PCR result. And then they also had 76 healthy, age-matched COVID-19 negative control patients who were also tested by the quantiferon assay. And for the COVID patients, they also categorized them according to COVID disease severity, and then all patients had been tested for total lymphocyte and neutrophil counts, as well as for multiple cellular immune components like TNF-alpha, IL-6, and others. And so what this group found was that COVID-19 patients had, on average, a 6-fold decrease in their ability to produce interferon gamma compared to healthy controls, with over 60% of COVID patients unable to generate any measurable interferon gamma in that mitogen control tube. And importantly, they showed that the 40% of COVID patients who did have sufficient interferon gamma in the mitogen to be able to result the test as positive or negative, they were lymphopenic to a similar degree as the quantiferon indeterminate COVID patients. And so what that suggests is that it's really aberrant T cell functionality rather than just low T cell counts that's leading to these indeterminate results. So one of their main conclusions is that the quantiferon assay and likely any IGRA in general may be limited in their utility to detect latent TB in severely ill COVID patients who, through some as of yet unclear mechanism, are unable to produce sufficient interferon gamma. And so the authors also did a pretty in-depth cellular immune marker assessment in these patients, which I'm not going to go into, but I will point out that similar to other studies, they found quite elevated IL-6 levels in these patients, which is a typical marker of cytokine release syndrome, and it's also a component of the Th2 immune response that can promote type 1 hypersensitivity, which has been linked to lung and other organ injury. And so because of that, these severely ill COVID patients are often treated with steroids as well as IL-6 inhibitors like tocilizumab, which is a monoclonal used more routinely for other rheumatic autoimmune diseases. And so prior to starting those therapies, patients are typically first pre-screened for various infectious diseases like LTBI. And so a similar approach has been taken prior to treatment of COVID patients. However, the question really becomes, given that over 60% of these patients are going to result as quantiferon indeterminate, how beneficial really is that approach? And it's something that I've discussed with our internal infectious disease clinicians here. There's no easy answer, I don't think at this point. We're still continuing to test all of our severely ill patients pre-treatment by the quantiferon assay. But yeah, the expectation and what we're seeing is that they're going to more likely than not be indeterminate. So I think it's just something that laboratories should be aware of that are offering the quantiferon assay, especially if they see that spike in indeterminate rates. So that's really why I chose this assay. I don't know, or this paper, I should say. I don't know if you guys have any thoughts. Have you seen quantiferon rates increase in your institutions?
So we don't perform it in-house actually, and it's a test kind of managed by our immunology lab rather than in our microbiology lab, so I can't comment to that. But in listening to you discuss this, Ellie, it's a nice paper and very helpful for laboratories that, monitor these metrics on a monthly basis. Should you be do you think there's value to adding a comment to the results? Have you considered that at all, Ellie?
So we have not as of yet, but it is something I think that we have considered doing. The comments go out to any patient, regardless of COVID. We don't know what they're being tested for. And I also worry that, our comment is already pretty long, trying to explain all the various
Yes.
interpretations of the quantiferon results. So I feel like it might get lost, which is why I thought more of an upfront approach to just educating our clinicians would be more beneficial. But yeah, comments are always something to consider modifying.
I thought this was a great paper, and it's one that I had initially chosen as well. Do you think, this is an ignorant question, is the bias towards a Th2 pattern seen in everybody who has COVID, or is it only seen in people who have more severe COVID?
So I believe it's in more severely ill patients where we're seeing this cytokine storm, if you will. So
it makes sense, and it makes sense that those are the people who you would also be doing quantiferon testing on.
Right. It's not like every COVID patient, gets a quantiferon test, but
Thank
of
goodness.
those that are the severely ill pre-treatment is where we're seeing quantiferon testing being performed. So yeah, interesting paper, definitely educational and something laboratorians, whether clinical microbiologists or immunologists overseeing the testing, should be aware of. So great. Trish, I think we're back to you.
Yeah, round two. Okay, so my second manuscript that I chose was the clinical utility of two high-throughput 16S rRNA gene sequencing workflows for taxonomic assignment of unidentifiable bacterial pathogens by MALDI-TOF MS. So this was published by Dr. Lau and colleagues from Hong Kong, China. It was posted online ahead of print this past month and will be officially published in JCM early 2022. So I'm kind of stealing from our choices from next year a little bit here. But like Ellie's choice in the last manuscript, this one became relevant to myself as our Sanger sequencer is on its last leg. And we continue to build our repertoire of NGS instruments and tests in the lab. And so we're considering converting our targeted NGS for bacterial and fungal ID by Sanger sequencing to an NGS platform. So in this study, they compared two commercially available 16S RNA gene sequencing tests using their built-in analysis software to full-length Sanger sequencing for species-level identification. And then they also looked at cost and time to result of the sequencing workflows. So the one commercial kit they looked at was the Illumina 16S metagenomic sequencing library workflow that was coupled with the MySeq reporter software. It's important to note that this kit covers the V3 and V4 variable regions of the 16S rRNA gene and only looks at a 460 base pair segment of the 16S RNA. The nice thing with Illumina sequencing is that you get higher base call accuracy with Illumina. The second kit that they looked at was a nanopore sequencing based kit, which is the 16S barcoding kit, and they use the Epi2Me software, which covers the entire 16S gene. So the nice thing about nanopore sequencing is you can get long reads, so you can sequence the entire 16S, so 1.5 kb gene. It allows for real-time analysis, but the worry when you start to think about species identification is that there's a higher error rate with nanopore sequencing, and so with looking at a single gene and potential with consensus sequence, can you overcome that sequencing error to give you the accuracy you need for bacterial identification? In addition to looking at the softwares that are coupled with each of the individual instruments, they also looked at an in-house BLAST software and 16S bacterial database. So this allowed for generate the results generated by both commercial kits using the same software and database for comparison. So they evaluated 172 clinical isolates that failed to identify by MALDI-TOF and MS. And, some of the holes that you can think of are some of our anaerobes or aerobic actinomycetes or non-fermenters, even some of the enterobacterales. And so they initially compared their results to the full-length 16S RNA gene sequencing, and then later looked at the accuracies of the results compared to a composite sequencing result, which is what they refer to as the reference standard, which included 16S, Illumina, and nanopore results combined. And any discrepancies with the reference standard, they went on to resolve it by whole genome sequencing. So as we think of it, despite the higher base calling accuracy of Illumina, the nanopore workflow in this study allowed for higher taxonomic resolution at the species level. But that's really mainly driven by the fact that the entire 16S gene was covered by nanopore. But in just looking at comparing these two kits, using their internal software, they had a 33% accuracy for the Illumina with the MySeq reporter compared to Sanger sequencing, and 88% for nanopore using the Epi2Me built-in software. When you looked at the BLAST, so the common software and database taking the results generated from both of those kits, the accuracy of Illumina went up to 66%, and the accuracy of nanopore was slightly lower at 83% accuracy. However, when they looked at the composite sequencing results as a reference standard, nanopore had 96% accuracy versus 69% accuracy by Illumina. The Illumina did show good concordance to the genus level, but not to the species level. And this is really reflected by the kit itself, where the V3, V4 region is good for diversity assessment of a microbial community, but is not the ideal area of the 16S gene to use to discriminate between closely related taxa. And so overall, the nanopore sequencing looked like it performed very well compared to the Illumina, but that's really, I think, the fact that of the region, the variable region that was in that kit and the shorter read length that it was looking at compared to the entire gene that you're comparing your nanopore and your 16S Sanger sequencing to. In terms of turnaround time considerations, for the Illumina-based approach on the MiSeq instrument with V3 paired end chemistry, it was a total of 78 hours, not including extraction time. And most of this time was due to the sequencing time on the MiSeq of 56 hours. Whereas with the nanopore approach, you could get your entire process completed minus the extraction time in 8 hours and 8.25 hours. And again, using only a smaller sequencing time of an hour. Interestingly, the costs too were in favor of nanopore in this study as well, where if you have 172 samples to perform 16S targeted sequencing on for bacterial ID, you could get the cost down to $28 on the Illumina, but you can the cost is only $17 or about $18 if you multiplex 24 samples on a MinION sequencer. And then they also talked about the cost of acquisition of these sequencers, where the MinION is $1,000 versus the MiSeq platform's $125,000. However, there are many other versions of Illumina platforms that are coming out that allow for variable sequencing depths, etc., that might be more suitable for this approach, especially if you think about volumes. I asked our lead of the area of how many we actually don't ID by MALDI that goes to 16S in a week, and it's about 5 to 10. And so really we would not get the cost efficiencies of the 172 multiplex samples together on a MiSeq, but perhaps this is something you could put on a lower throughput platform like an iSeq. So overall, this is a nice first study looking at the performance characteristics of 2 commercially available kits for 16S on different NGS platforms for bacterial identification. But it's really important to highlight that taxonomic resolution is dependent on the sequencing read length and location of the 16S rRNA gene being sequenced, the capacity of the 16S reference database, and choices of the analysis pipeline. So I think that's reflected in the results that we see here. But definitely very helpful as we consider some of the questions and converting to NGS for our targeted 16S and fungal identification by D1, D2, and ITS.
So Trish, has this helped you decide which way you're going to go?
It hasn't helped us decide, but we are going to continue to compare both platforms in our lab. The first step is we're just going to try to take amplicon from our traditional methods and put them and index them and try to library prep them and put them on Illumina versus nanopore. But we're also going to look to see if we could use the entire 16S gene by the nanopore approach as well, because that's interesting to us. Because right now our method only sequences the first 500 base pairs of the 16S RNA gene, so the V1, V2 region, the V1, V2 variable region. So it'll be interesting to see where it goes. Our initial attempts look promising at just taking the products into our standard Sanger sequencing, taking the amplicon from there, and library prepping them and putting them on Illumina versus the MinION.
Great. Thanks, Trish. Alex?
Yep,
Oh.
I think I'm up for the next one.
Yes.
So my second paper was multi-center post-implementation assessment of the positive predictive value of SARS-CoV-2 antigen-based point-of-care tests used for screening of asymptomatic continuing care staff. And the first and last authors were Drs. Kanji and Venner, and there was a variety of institutions listed, but University of Calgary and the Public Health Laboratory, Alberta Precision Laboratories seem to be the main ones. This is a very straightforward, short paper, so this will be a quick one. They were interested, of course, there's been a lot of interest broadly in using periodic, frequent testing in the workplace or other places to reduce transmission of SARS-CoV-2. And to do that, you need some kind of point-of-care test that will give you a rapid result. And for the most part, that will mean that you will be using an antigen test. There are point-of-care tests available by PCR, but they're much more cumbersome and a little bit slower and more expensive. So it's usually an antigen test. And the concern here, which is a hobby horse of mine, is whether positive results are reliable in a low prevalence population, such as an asymptomatic population. We're going to be talking about the specificity of the test, and I think everyone knows specificity is the ability of a test to correctly identify people who do not have the infection. So if you test, the specificity of 99% means that 99 out of 100 people who don't have the infection will test negative, and 1 will test positive. And then the positive predictive value, which is the chance that somebody who has a positive result actually has the infection. Specificity is not related to prevalence of disease. Positive predictive value is highly related to prevalence of disease. Anyone who's ever heard me give a talk has heard this whole thing before. So the question they asked is, what, in their circumstances, what's the positive predictive value of a rapid antigen test when it's used to screen asymptomatic individuals, employees who are working in the healthcare setting? So this was a program that was rolled out in Alberta, Canada, and it's done in the context of routine masking and routine questionnaires about symptoms for people who were working in the healthcare setting. Vaccination is implemented during the course of the study, and by the end of the study, a high percentage of people were vaccinated. And in this screening protocol, what they did was to use either the PanBio COVID-19 antigen rapid test or the Veritor COVID-19 antigen rapid test. Both of those are lateral flow assays, and these were being rolled out to a number of continuing care facilities. And it was a mix of what was available, what the facility preferred, that determined which of the two tests that they did. Testing was done once a week, routinely, and they could increase the testing to twice a week if there was an outbreak at that specific healthcare facility. Anyone who had a positive test had a second sample collected, and reverse transcription PCR was done on those to determine whether the antigen test was a true positive or a false positive. So over a 10-week period from late February to early May of 2021, 369 sites participated, and at those sites, a total of 71,847 tests were done, so an enormous number of tests. Most of those were PanBio, so 54,158 were PanBio, with about 17,500, give or take, being Veritor. 87 rapid antigen tests were positive, so a very small percentage, only 0.12% of the samples were positive. And of those 87 positive results, 39 of them could be confirmed by PCR, which is 45%. So the other 55% of the rapid antigen tests were false positives. And interestingly, I was interested to see that the false positive rates differed between the two assays. So the Veritor had a false positive rate of 76.6%, where the PanBio had a false positive rate of only 30%. The positive predictive values are the inverse of that, so it's 23.4% for Veritor, positive predictive value of 70% for PanBio. I just would want to read a few things here from the discussion, because they have a nice little section about what does a false positive mean? How does it affect people? And they point out that it can lead to loss of income due to the need to isolate, collateral effects on close contacts, psychological damage due to misdiagnosis, stigma, and fear of infecting others, especially loved ones who could have poor outcomes. And in healthcare settings, the need for isolation in response to a false positive result can lead to staff shortages, which you two may be familiar with, as am I, adding further stress to other employees and to patients. So a false positive result is not a small thing. This is something we see over and over again. It's a lesson we learn over and over again. Testing in a low prevalence population will result in a low positive predictive value, even with a very high specificity test, because no test has perfect specificity. And this is getting a lot of attention now due to COVID-19 testing, but all of us lab directors might reflect on whether this is affecting any other tests in our laboratory. So for example, if you are in an area where Neisseria gonorrhea infection is very uncommon, but you're doing a nucleic acid amplified test for GC linked to a test for chlamydia, you're testing a ton of people for gonorrhea, and there's a risk inherent in that of having false positives. That's one I was reflecting on for my own laboratory. So it's a classic lesson, but I think one that's being reinforced quite a bit during the pandemic when rapid testing is being rolled out quite broadly.
Thanks, Alex. Yeah, I agree. I think as laboratory directors and as trainees, we now all know the importance of PPV maybe much more than we did pre-COVID, but also the population, the general population, I think knows a lot more about positive predictive values and sensitivity and specificity. And I thought this was a really nice paper kind of underscoring the importance of using the right test at the right time. But so I think it's interesting that you picked one study showing poor sensitivity of nasal swabs. And all of our over-the-counter antigen testing is done on nasal swabs. And now you're showing us another study of not great positive predictive values for 2 antigen tests. So, my personal faith in antigen testing is continuing to falter. So my question is, in Dr. McAdams' opinion, when is the best time to use an antigen test?
I thought you were going to ask me if I was depressed or something.
Oh.
I think
that's a separate session.
I think rapid antigen tests do have some value. I think that it's relatively limited. So to my mind, and we've seen lots of studies showing that rapid antigen tests are more accurate and more sensitive in people who are symptomatic. So clearly in some symptomatic settings where PCR is not available for rapid testing and a rapid result is badly needed, that's a time you might want to consider using it. There are some schools that are using rapid tests on people, on students or employees who become symptomatic during the school day to decide what to do. Clearly, if they show up symptomatic, they should not be going to school or to work. So I think there's some utility there. I am not enthusiastic, although I wish I were. I'm not particularly enthusiastic about testing before getting together in social settings where people are asymptomatic, because I think the sensitivity of these tests is a little bit lower. That having been said, to my mind, the solution to all of this is vaccination. We need needles in arms, and that will reduce the need for testing and reduce the confusion around testing.
Agreed. Awesome. Thanks, Alex. So I'll switch to my second paper, which also is related to TB, but this time it's direct detection of active pulmonary TB. And what really drew me to this paper was the specimen type that they were testing, which is urine. And I'll be honest, that kind of made me do a double take when I first read the title. But this paper is by Dr. Amy Orskovich from the University of Washington in Seattle and is entitled Diagnosing Pulmonary Tuberculosis by Using Sequence-Specific Purification of Urine Cell-Free DNA. And the authors really, I thought, nicely outlined some of the challenges associated with TB testing currently, including issues like sputum collection, challenges in some patients, including kids. And, although we have a significant improvement in TB diagnostics with some of the rapid sputum-based tests, they still have imperfect sensitivity, particularly in patients with paucibacillary TB, for example. So urine became an intriguing specimen type for this group. It's easy to collect, it has a minimal infectious risk, and prior studies have shown that TB-specific cell-free DNA is present and detectable in urine, although with some quite significant differences or variability in sensitivity ranging from 0% to 79%. And perhaps not surprisingly, one of the reasons for that low sensitivity in urine is due to just low overall concentration of TB DNA fragments in that specimen type, and also because of the short length of those DNA fragments. So for comparison, while peak cell-free DNA fragments in plasma is about 170-ish base pairs, DNA fragments in urine range anywhere from 30 to 110 base pairs, with bacterial cell-free DNA expected to be shorter than 60 base pairs because of its lack of protective DNA-associated proteins. And so to improve on the sensitivity of TB-specific cell-free DNA detection in urine, this group developed a TB sequence-specific purification method that targeted the insertion sequence 6110 using DNA hybridization capture probes immobilized on magnetic beads to extract short-length cell-free fragments of this particular TB sequence from 10 mils of urine. And then they used that purified material to do a short 40 base pair targeted PCR. And so to evaluate the accuracy of this method, specifically for detection of active pulmonary TB, they enrolled 59 patients from South Africa, 10 of who were TB negative, 49 which were TB positive. And that positive case definition was that the patients had a positive sputum expert, Cepheid expert MTB RIF result, the presence of one or more TB symptoms, and then being on TB treatment for less than 72 hours. And then they also had 14 healthy control volunteers from the US for a total of 73 participants. They used the expert assay as the reference standard for comparison of their method, but they also compared their assay relative to sputum culture results and also the allele-determined TB lipoarabinomannan or LAM antigen lateral flow assay, which is done on urine. So they started by showing that they have about 92% recovery of a 50 base pair positive control using their method, which is pretty good. And then cutting to the chase, compared to the expert assay, their purification and short length PCR assay in urine had a sensitivity of 84%, missing 8 of the positive cases, and a specificity of 100%. And if you dive in a little bit more, their assay was positive in all 19 sputum culture positive patients and all 17 LAM antigen positive patients. They did observe significantly lower sensitivity in smear negative patients at 76% versus smear positive patients, for which the assay was positive in all 19 cases. And they also looked at TB cell-free DNA concentration in urine and found higher positivity and higher concentrations in patients who were recently started on anti-TB therapy versus treatment-naive patients. And they suggested that the cell-free DNA concentrations may initially increase due to the bactericidal activity of the anti-TB therapy, but they only included patients with less than 4 days of therapy. So what this looks like long term is unknown, but the potential of using an assay like this to monitor response to therapy, I think, is intriguing. So overall, although this method isn't something that can be easily implemented in resource-restricted settings, it did meet the WHO optimal criteria for a biomarker-based non-sputum TB test, which includes a minimum sensitivity of 68% and 100% in smear negative and smear positive cases, respectively, and they did meet those criteria. And again, I just found the thought of using urine as a sample type for this particular disease to be intriguing. I think sometimes urine is maybe an underappreciated specimen type, but increasingly I'd say that it's becoming maybe more apparent that urine may be a more valuable specimen source, as this study suggests, but we're also seeing increasing evidence that it's a better source for PCR testing of arboviral infections. And actually, there was another paper in JCM recently suggesting that urine is a preferred specimen type for detection of strongyloides IgG antibodies. Still can't quite wrap my mind around that one, but it's definitely an intriguing and interesting paper and concept. So yeah, urine might be the next big thing.
Anybody want to make a liquid gold joke? Or just... I was urine has become very fashionable, with good reason. I shouldn't say fashionable. It's come into its own as a potential sample type for infections outside of the urinary tract. When this started, I was not optimistic, and I was wrong. It seems like much larger molecules and in much greater quantity show up in urine than I ever would have guessed.
Yeah, I agree. Looking for antibodies in urine, never would have really thought about that one. But the fact that we can, this study showed pretty good sensitivity for detection of pulmonary TB in urine. I think it was a very cool study, and I thought really well done.
It's interesting that they talk about monitoring, response to therapy, though, with the thought that it increases in the like after treatment. So they really need to have to monitor long term to see how those values, when they came down, how they came down, etc.
Agreed.
Interesting.
Yep, definitely agreed. All right, Trish, you want to close out the third round?
Yes. Okay. So round 3. So the third paper I chose was reflex detection of ciprofloxacin resistance in Neisseria gonorrhoeae by use of the SPEEDx resistance plus GC assay. This was published by Dr. Lee and colleagues from Melbourne, Australia, and published in the May 2021 edition. So we all know that there's an increasing incidence of gonorrhea, which is a major public health threat. Dual therapy, empiric therapy with oral azithromycin and intramuscular ceftriaxone is recommended. However, with recent increase in resistance, individualized therapy based on molecular detection of resistance, or also known as resistance-guided therapy, has been suggested to improve antimicrobial stewardship and delaying the emergence of resistance. And so resistance-guided therapy for ciprofloxacin has been incorporated into gonorrhea treatment guidelines in the UK and has recently been shown to be feasible and effective in a recent multi-center clinical study in the US. So ciprofloxacin resistance in Neisseria gonorrhoeae occurs primarily through point mutations in DNA gyrase A gene, or GAR-A, with a single point mutation at serine 91 codon, so GAR-A S91F mutation being the most common, and is predictive of ciprofloxacin resistance. So this study evaluated the performance characteristics of a commercially available kit, the SPEEDx resistance plus GC assay, to detect gonorrhea, Neisseria gonorrhoeae, and ciprofloxacin resistance based on the GAR-A S91F mutation. They compared the detection of Neisseria gonorrhoeae to the Aptima Combo 2 assay. And they also determined the genomic stability of molecular determinants of ciprofloxacin resistance in a large collection of publicly available GC genomes. So they tested 445 clinical samples from 336 patients for chlamydia trachomatis and Neisseria gonorrhoeae using the Aptima Combo 2 transcription-mediated assay. They tested these within 24 hours of collection and included anorectal, pharyngeal, and urogenital sample types and collected them in the Hologic Aptima unisex specimen transport tubes. They then took the remnant samples and extracted nucleic acid using the Kia Symphony and performed the PCR for Neisseria gonorrhoeae and the GAR-A S91F mutation using the Resistance Plus assay on a light cycler instrument. And they analyzed the results with the appropriate software, which interpreted it as detected or not detected for GC, and whether GAR-A was a wild type or a GAR-A S91F mutation was detected, or whether it was indeterminate. So in terms of accuracy for detection of Neisseria gonorrhoeae, the sensitivity was 94.8% and 100% specificity. In those samples where there was a discordant, where the Aptima detected GC but the SPEEDx did not, the relative light units on the Aptima assay was significantly lower in these samples, and they were mostly associated with extragenital sites. So the authors hypothesized this reflects lower analytical sensitivity of the Resistance Plus GC assay and the lower bacterial load at particular anatomical sites. In terms of ciprofloxacin resistance, 87% of samples that were positive by Aptima generated a JAR-A result by the resistance plus GC assay. Of those, 63% were wild type, whereas 37% demonstrated the point mutation associated with ciprofloxacin resistance. The remaining 13% generated had an indeterminate result for JAR-A, and these indeterminate results were more significantly found around in extragenital sites than compared to urogenital sites. And then the genomic, and looking at the genomic assessment of how well JAR-A S91F could predict resistance globally and in various lineages, they took greater than 8,000 non-duplicate global isolates with available MIC data for ciprofloxacin obtained from the Pathogen Watch website, where and of those, approximately 3,100 were phenotypically resistant to ciprofloxacin, and mutations were evaluated within JAR-A and PAR-C, which is topoisomerase 4, which is a secondary target. Mutations can occur resulting in resistance to fluoroquinolones. So overall, of those 3,100 that were phenotypically resistant, 98.6 had the S91F mutation. And of those 98.6%, 99 also had a secondary mutation within JAR-A, and 82% had another mutation in PAR-C. So overall, this work really supports the potential feasibility of implementing resistance-guided therapy for gonorrhea and supports the use of JAR-A S91F as being highly predictive of ciprofloxacin resistance across across a range of GC lineages from multiple geographic settings. So it just, in the era of antimicrobial stewardship, this might be more of our focus moving forward, is not just detecting whether the sample's positive for a Neisseria gonorrhea or not, but also looking at resistance mutations to help us guide therapy in the patient.
I talked about a similar paper at ID Week, one that was published in Clinical Infectious Diseases, and this is clearly a coming thing. But I'd be curious to hear from the two of you, doesn't it seem like for this to take off, it needs to be integrated into our high throughput platform? So it would be a real selling point for the manufacturers to say, here's our test for GC-CT, and in addition, you will get this resistance marker for Neisseria, rather than having to pull those samples and do a second test.
Absolutely. I completely agree, Alex, that we need to have it on our high throughput instruments. But it does show, and I think the authors were getting to this, that you can do a reflex on a secondary method of those that are positive on your throughput platform, and then use those that are positive to these resistance testing. But ideally, they would be all built in within the same system moving forward. And I definitely foresee that as what we're going to see in the future in this area.
I would agree. Thanks, Trish. Alex, you want to go
All right,
with your third?
Yeah, my third one here, and this one is the one that I said was sort of a little bit out of left field. And I say that because it's about biosafety. We don't often cover biosafety in JCM, but when we have a really good paper that is related to the clinical laboratory in terms of biosafety, we will certainly take it. So the title of this one is Handling Burkholderia pseudomallei Isolates Without a Biosafety Cabinet. And it's a great title because it tells you exactly what they're going to do. So Dr. Gessup and Dr. Norton are the first and last authors here. Trish, you were the editor on this one. Great job. And what they asked is whether it might be safe to perform routine bacteriology culture and testing of Burkholderia pseudomallei without the use of a biosafety cabinet. This organism, of course, is the cause of melioidosis. It's an environmental organism found in the equatorial regions. In the United States, this is a Tier 1 select agent. And such organisms, to be Tier 1, they have to, quote, present the greatest risk of deliberate misuse with significant potential for mass casualties or devastating effect to the economy, critical infrastructure, or public confidence, and pose a severe threat to public health and safety. The biosafety in microbiological and biomedical laboratories, or BMBL, recommends BL3, the same precautions as we use for Mycobacterium tuberculosis, when handling this organism. But the authors point out, rightly, that not all laboratories have the capacity for BL3. And in fact, many laboratories don't even have a biosafety cabinet or laminar flow hood. So in Australia, where this study was done, the organism is endemic in some regions. Handling in a biosafety cabinet is recommended. In Queensland, where the study was done, only the state melioidosis reference laboratory has a specific, or had a specific occupational safety procedure. And they required that staff members who had risk factors for melioidosis handle the cultures in the biosafety cabinet, but those who did not have risk factors for melioidosis were not required to use a biosafety cabinet. And they point out that there are only 2 case reports of laboratory-acquired infections with Burkholderia pseudomallei. And so I went and pulled those 2 case reports, and in both cases, it was a pretty dramatic exposure. So in the first one here, which is a case report from 1968, it says that 3 days prior to admission, the continuous flow centrifuge in which large amounts of the bacterium were being handled developed a leak, and concentrated suspension of organisms was sprayed into the air over the walls and the benches of the laboratory. Using her bare hands, she cleaned up this mixture of media and organisms. At the time, she had an ulcerative lesion at the base of her right index finger, and she starts to get sick 3 days later. The second one here is published in New England Journal of Medicine, and that was published in 1981. And again, there was, sort of a surprising degree of exposure. So this person, their exposure was they were handling large quantities of the bacteria because their job was to grow large batches of resistant gram-negative organisms and prepare them for extraction of aminoglycoside inactivating enzymes. This process, which involved disruption of the bacterial cell wall by sonication, was performed with a Raytheon sonicator in an open flask system. Sonication was not done in a biosafety cabinet. So there are laboratory-acquired infections, but they really involved significant exposures. So getting back to the paper, what they did was very straightforward. They recruited 4 laboratories, and they gave a questionnaire to staff in those laboratories to estimate over a 10-year period how many times they had handled Burkholderia pseudomallei outside of a biosafety cabinet. So this clearly depends on the memory of those laboratory employees. They then also performed serology for Burkholderia pseudomallei on all of those employees. And they did that by 2 methods, indirect hemagglutination for total antibody and an enzyme immunoassay for IgG. So that's part 1. Part 2 is they did a bioaerosol detection. And here they used Burkholderia thailandensis as a surrogate organism. And they did a number of routine bacteriology procedures, opening plates and streaking plates and setting things up for MALDI-TOF and those kinds of things in a biosafety cabinet that had been shut off, and they had an air sampler 30 centimeters away from the spot where the plates were being handled or the procedures were being done. So in terms of the results, they had 30 staff members involved, and there was a total of 1,419 estimated events in which staff handled Burkholderia pseudomallei. 89% of those were outside of a biosafety cabinet. And during that time, the Queensland region had approximately 300 culture confirmed cases of Burkholderia pseudomallei, each of which would have been worked up to the reference laboratory. Serology was negative in all 30 staff members. For the bioaerosol portion of this, they did 78 bioaerosol detection experiments. They opened plates, they tilted the plates, they made a McFarland standard, they performed catalase and oxidase tests, and so on. They collected large volumes of the air adjacent to that testing, and they found an average of 18 colony-forming units of environmental organisms, but they found none of the Burkholderia. So in their discussion, they note that between the 2 regional reference laboratories, about 700 isolates would have been worked up at BL2 without a requirement to handle all of the samples in biosafety cabinets, and there were no reported laboratory-acquired infections. So for me, this paper did convince me that the risk of working with this organism without BL3 is low, and it may be safe to work with it on the benchtop if a person does not have risk factors for melioidosis. That said, it's important for us to be mindful of local guidelines and regulations, so I wouldn't suggest anyone go running off and start doing this. This would be something to do with careful consideration.
Yeah,
Yeah.
I think as the editor of this paper, when I received it, I'm like, oh, it's challenging, what our local regulations tell us to do. So it's giving me a little bit of heart palpitations, but it does show that, the risk is relatively low for the laboratory workers, but we do need to take that the safety of our techs into consideration and make sure that we follow those local regulations. But let's just say a Burkholderia pseudomallei gets worked up in the lab by accident outside of the biosafety cabinet. You only realize it by MALDI-TOF ID or something later. It's helpful to know that the risk is relatively low in terms of laboratory using our standard methods in the lab. So I do think the study is helpful, even for those that have more stringent local regulations, that when these exposures do occur in the lab, that we have some sense of what is the potential here in terms of risk to the staff members.
Yeah, I think that's a great point. It points out another potential use of the paper that is in the follow-up to possible exposure.
Definitely. Thanks, Alex. So I think we'll move to the last paper for today. So this one is in the parasitology realm, entitled Comparative Performance of the Latest Generation and FDA-Cleared Serology Test for the Diagnosis of Chagas Disease by Emily Kelly from UCSF. And I chose this article because I think it provides a nice update and pulse check, I guess, on current and future Chagas serologic tests, which is somewhat of a timely topic given the current pause on parasite serologic testing at the CDC, which has led to some scrambling to get at-risk patients appropriately tested. So as a refresher, diagnosis of chronic Chagas is entirely serology-based and currently requires reactivity on two unique assays which utilize different Trypanosoma cruzi antigens. And if those results are discordant, then a tiebreaker test is done typically at the CDC. So currently, Chagas testing is done using one of 4 FDA-cleared assays, although to my knowledge, at least, there's no at least large laboratory that's offering a multi-assay algorithm at the moment, which is in part due to reagent availability issues. So one of the hopes is that in the future, there is a single serologic test that we can rely on for Chagas antibody detection rather than using a multi-assay approach. And then I also want to point out that there are 2 assays with FDA approval for blood and organ donor testing, the Abbott Prism and the OrthoELISA, which were also evaluated in this study. So in this paper, they used 710 blood donor plasma samples from the American Red Cross, amongst which 262 were seronegative and 448 were confirmed as Trypanosoma cruzi antibody positive by the OrthoELISA or the Abbott Prism assay, and then a separate confirmatory test. And then amongst the 448 positive samples, country of birth was available for 228 of the donors. And country of birth is important because there are different T. cruzi genotypes throughout South and Central America, and they don't really all share a high level of sequence homology at key antigenic epitopes. And so as a result, you can have some significant variability with respect to serologic assay sensitivity depending on the type of T. cruzi genotype antigens used and with what genotype the patient was infected. So using these 710 samples, they tested them on 4 assays with on the 4 assays with FDA clearance, which include Hemogen ELISA, Wiener Chaga Test 3.0 ELISA, the InBios lateral flow assay, and then the OrthoELISA, which even though it has a diagnostic claim, again, it's only used or marketed in the US for blood donor testing. And then they also looked at 3 assays that do not yet have FDA approval, which is the Chaga Test 4.0 ELISA and then the Wiener Losado ELISA. And all of these assays are based on different T. cruzi antigen preparations, which I won't go through in detail, but they are somewhat varied. And then they also looked at the Abbott Prism chemiluminescent assay again, which is only approved for blood donors. And ultimately what they showed is that all of the new, not yet FDA cleared assays had 100% specificity in this sample set, which was similar to the currently FDA-cleared assays with the exception of the in-bios lateral flow assay, which had a specificity of only 91%. And to be honest, these specificity results for the currently available assays that they reported, that high specificity was pretty surprising to me because we've used a few of them in our lab and we've definitely had some concerns about false positives, but I think that difference is likely due to the different patient populations tested. So the otherwise healthy blood donors in the study versus the sick symptomatic patients that we see in the lab. Turning to sensitivity, though, they found that the Chaga test 4.0 ELISA, which again is not yet FDA cleared, had the highest sensitivity at almost 99%, missing only 5 confirmed positive cases. And for comparability, the next highest sensitivity assay was the in-bios LFA at about 97.5%. And then the Chaga test 4.0 also, not surprisingly, had the highest sensitivity amongst Chagas positive donors from South and Central America at 100%, and nearly 99% sensitivity amongst donors originally from Mexico. Again, for comparison purposes, the sensitivity among the current FDA-cleared assays in this donor set ranged from 82 to 98%, with the lowest sensitivity observed in donors born in Mexico. So I guess the take-home point here is that the Chaga test 4.0 seems to provide the best sensitivity and specificity, at least amongst blood donors, compared to the current FDA-cleared assays and potentially future assays. And it offers this enhanced sensitivity amongst donors of Mexican descent, where the TC1 genotype is the predominant genotype, but it is highly, highly heterogeneous. Again, this assay doesn't have FDA clearance yet, and it needs additional real-world clinical assessment. But the data overall would suggest that it may provide a notable benefit over the assays that are currently in use and may potentially allow us to use a single tier testing algorithm in the future. So yeah, it was kind of exciting to see a test for Chagas disease that provides such improved performance compared to what we currently see. So yeah, I'm kind of excited to see where this assay goes in the future and whether it can get FDA clearance hopefully soon. So.
Great.
Yeah, and I know you guys probably don't do Chagas serology testing,
No.
but I was really excited.
Yeah, no. And have you seen a big increase in requests at Mayo because of what's going on with the CDC?
We have actually had to take down our Chagas testing because of reagent issues, but we test forward a lot. So yeah, it's definitely, we've had to scramble, like I said, to get testing done for some of these high risk patients. So we're looking forward to getting assays back, assay availability back online, and then having the CDC come back up for testing. I think it will be important. So
I was just going to say, for me, Chagas is one of those things that whenever I'm asked about it, I look it up. Because
I call
I'm not
Ellie.
asked frequently. Yeah, exactly.
Well, yeah. Yeah, that's what we're here for, us reference labs. So I guess thank you, Trish, for joining us today. Excellent paper selections. And thank you to all of the listeners for listening today. And we look forward to the next episode.